So we're going to move to the next session on our agenda, where we're going to focus on racism and health disparities, health inequities. Our speaker, keynote speaker, is Dr. Eliseo Pérez-Stable. We're very honored to have you here with us today. He is the director of the National Institute on Minority Health and Health Disparities at the National Institutes of Health. And I did my homework, and I found an extensive and impressive record of research and scholarship. You've been a leader in health and disparities research in the Latino community and in other ways. Many articles and grants and awards. But the award that I liked the best, and it's related to what Dr. Barry talked about, is the multiple times while you were practicing at UCSF, you were selected as one of the best doctors in America. And I have to assume that that's not, as my children call me, a fake doctor, but a real doctor. So thank you very much. That really tells us a lot about who you are. So thank you for being with us today.
All right, am I on? Yes. So thank you, Sarah, and thanks, Sandro, for the invitation, and to all of you for being here. It's a real honor to participate in this group with such great, talented people, and I got to meet Alfredo Moravia and others who I've known for many years, or have known their work for many years, and colleagues who I've known for many years. I'm not going to talk a lot about NIMHD, but I did want to start with a little bit of vision on that, since I didn't have the opportunity to do that in another context, and I assume some of you might have questions. This is a talk on racism, so and it's not a topic that I'm particularly facile in. So I did a little bit of review and thinking about how am I going to present it about this. So talk about categories, definitions, so organize it for myself using these three categories of racism. And then as a clinician, or former clinician, it's been a year and a half since I saw patients directly. I want to talk about the healthcare setting and how that gets involved, and then give you some ideas of how there are interventions that could mitigate these effects, although, again, I don't have the solution. So NIMHD really focuses on two components. One is minority health, and minority health is really the attributes and characteristics of the racial, ethnic minority groups as defined by the census. And if eventually these will all become one human species, as we heard earlier, it won't be when I'm around, because it's going to take a long time. We believe that all the minority groups in the US have some level of social disadvantage that is fundamentally driven by having been subject to discrimination. We know that and acknowledge that this is very different. The legacy of slavery in the US has particular characteristics that make it different than slavery as it has existed in other societies in human history. The discrimination that the American Indians suffered in terms of war is very different than others, and Latinos with immigration issues are very current today, Asian Americans also with immigration and internment camps, et cetera. So I think there is a common theme in this definition. And then our research on these factors that lead to outcomes is what minority health research is about, independent of whether the outcome is worse or not. And I think this gives us the green light to look at why Latina women have the longest life expectancy in the US, until at least they have other data on Asian women, which may change that. David Williams, who here is in town, made this definition many years ago about race. He said societally, and I'll read it to you, societal constructed taxonomy that reflects intersection of particular historical conditions with economic, political, legal, social, and cultural factors, as well as racism. No mention of biology here. I think we know a lot more since 1994, but I think, and we can have a conversation about that if relevant. You're familiar with the OMB categories. This is the official terminology that they use, African American or Black, Asian, even though it's quite complicated. It's over 30 countries. And South Asians don't technically match into this race with the data that we know now, but that's Asian. American Indian or Alaska Native, Native Hawaiian or other Pacific Islander, which is not the same as Asian, and frequently one sees the two lumped together as AAPI, and this is just wrong, and we should make sure we disaggregate those two to begin with, as well as others. And then Latino or Hispanics, which is an ethnic group, is the only recognized ethnic group by the census. Involves 20 countries. People write about how different we all are, and I come back, well, but we're more alike than different. That's a separate conversation. And then white. The proposal for 2020, whether it gets approved or not, has that to have another ethnic group called Middle Eastern North African, or MENA, and then to eliminate the two-part question that always asked about, are you Hispanic or, not, or Latino, and then asked race. Says about 40% of Latinos don't answer that question correctly and don't understand it. They kind of say, I already told you my race, why are you asking me again? Lots of meaning behind race. We heard some of them. It is fundamentally a social and cultural construct. I don't think the geneticists argue that at all. It is, though, a geographic origin of racially classified groups based on phenotype, based on the appearance, on how people look and evolve differently. Remember that the origin of human species as they exist today is East Africa, so in some place we're all Africans. But these founder populations, as they migrated out, were quite modest, and in fact, for thousands of years, did not increase in number. So there was a fair amount of concentration, and only in the last 500 years or so have we seen a globalization of humans moving around the entire globe. In the US, race was always about whites and blacks, and comparisons of whites and blacks, whites always were better off than blacks, so it was simple. Things changed in the 60s with the immigration waves and the recognition of Latinos and Asians being present in the US, and so that, has, I think, made things more complicated. Remember, we're not that far removed from the one-drop rule. 1/16 black, you're black, and that was actually codified in some states. And similarly, American Indian tribes used the 1/16 mixture, 1/8 mixture, as to see official members of some tribal nations. No one talks about gradations of pigment, or at least very little research has been done on that, yet it is actually a driver. It has been shown that if you're lighter skinned in a white-dominant society, you do better. People are more likely to accept you. I'm Cuban, and in Cuba, people who would normally be considered white in the United States were black. And so the cultural definition of race, I think, will vary sometimes by location, and this is consistently true, at least in the Caribbean and probably also in Brazil. And then we have the mixed race. What do we do with that? I mean, it used to be uncommon. Now it's more common, yet only 3% of the US Census respondents check that box. So clearly there's something about that box that gives people identity and that still has meaning. So we will at some point maybe not be talking about that, but I think that day is not here yet. Health disparities, from our perspective, focuses on not just race, ethnic minorities, but also poor people of any race or ethnicity. So less privileged socioeconomic status, of whatever their race or ethnic background is. We're also mandated by Congress to look at rural residents. We believe this is underserved residents, so these are mostly poor people, poor rural residents, but there is recent data that would imply that if you live in rural communities in the US, you have higher morbidity and mortality across the board compared to urban dwellers. So that, I think, is a relevant point. And then others subject to discrimination, and I didn't change the slide, is really also we added that we made a declaration in October, vetted by NIH leadership and the department, that sexual gender minorities would be included in our disparity populations. And then we look at disparity populations when they have an adverse effect that we consider is frequently attributed to the social disadvantage of having been subject to discrimination and all that it came with, but also other factors, whether it be behavior, environment, cultural environment, physical environment, or biology. In that context, our scientific staff, led by Dr. Alvidrez and others, created a framework that I've tweaked here and there for different presentations to try to capture what our research is about. You will notice that racism is there, discrimination, racism in the different columns, both at the individual level and the interpersonal level. In the community level, you have discrimination, social cohesion, and then across in the societal level, you have structural racism. So the topic for today is of great interest to NIMHD. It is under-researched, we believe, and I think we invite the community to really look at this as a potential opportunity for future work at all of these levels, whether it be behavior, biology, physical, social environment, and definitely the healthcare system, where I think much more needs to be done. So let's dwell a little bit into these different categories. This is an old cartoon that just sort of captures the notion that, racism is part of what we are about. I like to say, well, it's institutional racism. It's the culture, it's the history. Not like individuals. People get very sensitive and defensive about, oh, you're not a racist. I'm not a racist. I'm not a racist. I have black friends, whatever. But it's really something that goes beyond the individual. So I think that's the first thing to break this apart. Recognize that it exists. But what are some challenges or myths, and then some challenges? So first, there's a tendency among scientists to say, well, this is ideology, this is advocacy, this is not science. So as a scientist, and especially at NIH, we need to be data-driven. And so I'm going to sponsor, as director of NIMHD, and we are planning to sponsor a scientific workshop on structural racism linked to also cultural competence or structural competence, whatever the staff come up with on this, and invite people to come and talk. NIH leadership is going to support it because we're going to do science. We're going to talk about data. We're going to say, well, what do we go from here? What are the research questions? We're not there to get up on the stand and just advocate a position. That's not the central role that we have. That's for others to do. Then there's also a position that researchers from the target population may lack objectivity, which is also a myth in my view. Daryl gave a great example. It's embarrassing that you were the first African-American research group that was studying this group. As a Latino researcher who started out working with Latino communities and Latino participants and serve in the San Francisco Bay Area, I take the idea that yes, there may be some lack of objectivity, but if we're scientists, we can do that, and perhaps we do more of it. We do better. We're better at recruiting. I don't know. There's not data on that, and if any of you get excited about that, you can certainly. We need data to say what do minority PIs do, because there's so few of us, or I was one, but 5% of NIH grants actually are awarded to either an African American or Latino principal investigator. So put it of RPG, of research grants. There's also this idea that, oh, racism is resolved, right? And there's just a few bad apples that are around. And I think that is undermined by the fact that this is institutionalized. And you don't dissolve history, especially a legacy of slavery in this country, with 30 years of civil rights movement activity. So, I mean, it's complicated, but there is that perception. And then that after Barack Obama was elected president, I remember speaking to a distinguished group of researchers in a group funded by Robert Wood Johnson Foundation, and I got asked the question, aren't we in a post-racial society now? It feels like we're different now. And of course, we know that is not the case, and the former president himself acknowledged as much. In the terms of challenges, I think emotional components must be considered. If you're an investigator of the group, and you have experienced this, you have to separate out the emotional components, or you have to acknowledge that your participants are going to have emotion related to this topic. And then the issue of scientific rigor. David Williams, in an interview of his that I read, who's a pioneer in this research area, mentioned that in the early 90s, when he was asked to write a review on this topic, he said, well, he just didn't find any data, any rigor in the publications that had come out on the role of racism. So he then went on to develop scales with others that have been used now consistently. So in order to, we need to describe, we need to have validated, standardized measures that to establish associations and then imply causal inference in well-designed either observational cohort studies. You're not going to get too many randomized trials. You be a racist, you don't. That's not feasible. But you get enough numbers in a well-collected, standardized data, observational data, you can make causal inference, I think, with fairly amount of certainty. So Tom Leviste and others have talked about this. So this is three categorizations that people have used in the literature. Far and away, the most common category is interpersonal. So this is where most work has been done. There have been good measures. It's what you as a person have experienced as discrimination, or perpetrators aren't often asked. That's another point that one can think about. And associations have been established. This is most common. Structural racism is my first reaction to this. Well, how do you operationalize this as a research construct? And that's why we're going to have a scientific workshop to see, is this really a systems construct, or can we actually develop clever ways of looking at different data points or variables and try to operationalize a structural racism construct. This brings in history, culture, institutions, codified practices that have perpetuated inequity, even though many of these have been no longer in existence. They continue to impact us. And then internalized racism, which is not new, but has clearly not been there's not been as much work done in this area, particularly with regards to health. There's been more work done in sort of individual effects from a social science perspective, particularly on in psychological effects. But it's the idea that you say, I don't have any discrimination, but then you've actually internalized the negative concepts of your racial ethnic group. Yes, all Mexicans are lazy. Oh, African Americans are culturally inferior. They're not as smart. I mean, these kinds of extreme positions have become internalized by the individual. So they, of course, do not experience any discrimination. Some data points to make the point. This is a survey done by Kaiser, National Survey on Latinos in America in the year 2000. Asked the question, past 5 years, were you or your family discriminated due to race, ethnicity? The first column is in general. The second column is in healthcare. And notice that African Americans are higher than Latinos, and that they're both considerably higher than whites. So, 17% of African Americans, 12% of Latinos said they had felt discriminated in their healthcare, where physicians, clinicians are expected to be different. And then this is an update, a different one, is a survey on Americans on race, so much broader topics were covered. Boy, not much progress. Past 30 days were you treated unfairly, this is 30 days now, because of racial ethnic background in store, work, entertainment, place, dealing with police, or getting health care. The first column is all of them. The second column is only the responses to health care. So again, Latinos are 14%, same as 5 years before. African Americans have gone down. Whites are about the same, 5%, which you could argue may be background noise in a survey of this type. So what's the data? So first of all, there are, the everyday discrimination scale, which is 9 items, is the most frequently used. Many of you probably have used it. It is a reliable and reasonably valid measure now that with time has been in multiple populations. There are issues with major events. So I think where the group started was, have you been a victim of racism in a major life event kind of thing? Get fired from a job, not get a job, get into a fight, these kinds of things, sort of like one does in other surveys about major life events. That has not been as useful because it is much less frequent as opposed to the everyday discrimination scale, which gives you a global measure. And mind you, none of these start off with race. They really talk about global discrimination and then go into, is it race, is it gender, is it class, or is it language? You could then adapt it to that context, or is it whether physical disability or other physical appearance. And then there's a vigilance scale, which tries to get at this idea of you potentially are worried about, the The stereotype would be African-American man walks into a fancy store in Georgetown and feels like, like 3 sets of eyes are on him as soon as he walks in the door. Does that happen to someone who is of a different race? And that's the kind of vigilance that someone with awareness and consciousness will experience. And what does that do to you? So effects on physical and mental health status have been described and reported on by a number of investigators, James Jackson being one, from multiple surveys. I think the best way to think about this then is to conceptualize racism as a form of chronic stress. So what we're measuring in the interpersonal discrimination scale is a measure of chronic stress, and that is particular to your group or your gender or your status. And then the effect of racism on physiological measures was sort of a second level of research on this. First linked to systolic blood pressure being elevated, and there are a number of small controlled basic behavioral studies that have shown this, as well as in bigger studies, levels of inflammatory markers, and sort of thinking about, well, chronic stress leads to more cardiovascular events, and what's the mechanism for that? Well, blood pressure, inflammation, and these biological connections that we think have become more important. The link the effects on mental health to heart disease. So if you get more depressed, we do know people have increased risk of cardiovascular event. And so this is, again, another pathway. I think creating these pathways where you have biological plausibility based on the data that exists that actually matter because this is the number one cause of death in the United States. And then there's all the impact on health behavior. So linkage to more smoking, at least in African Americans, and in some groups, problem drinking. So that means binge or excess drinking, and then other substance use. Data that actually links discrimination as we measure it to disease outcomes in terms of mortality or events, heart attacks, are less robust. And I think this is an area that needs, in my view, more research. I show this as an example, although we are not in Argentina. This is from data from Northwest Argentina that we collected, led by Dr. Alderete, who's the lead author. And it was a cohort study of 8th graders in Jujuy. And Jujuy is more like Bolivia than Buenos Aires, in case you've ever been to Argentina. And the sample was half indigenous, 30% mixed, and 15% European. The point here is that race is not a US issue alone. And 25 years ago, when I went to Argentina for the first time and brought it up with my colleagues there, they kind of said, oh, no, it's all about class here. We don't deal with race. And then when I lived there, I go, well, what about the indigenous people, the Bolivians who are here, who are immigrants here, or the Paraguayans? Because there are virtually no African ancestral people in Buenos Aires. And if you go to Jujuy, the kids had no problem saying, yeah, I'm Indian. And they could name it their group. Others said they were mixed, and the Europeans are a minority. And then we asked them about exposure to racial insults, and these were not subtle. I mean, these were like insults, the equivalent of the N-word, if you wish, or worse, about being Indian in that society. And found that those who were Amazonian origin, so not the majority indigenous group, the minority indigenous group, was strongly associated with current smoking 2 years later, as well as those who were mixed youth, but not the Andean origin group. And so I think this is an operationalizing a measure of discrimination with an outcome that we think matters. Internalized negative racial attitudes do seem to moderate effective discrimination. This is work from, I didn't put the citation here, David Che, who is at the University of Maryland, analyzing the National Survey of American Life, 1,200 African American men. No main effect of discrimination on predicting cardiovascular history. Used a modification of Framingham to say, well, here's your responses, what's your risk of heart disease, and use that as his outcome. But men who endorsed negative beliefs about blacks and reported no discrimination had the highest risk of cardiovascular history risk. So in a way, it's operationalizing and saying, well, maybe there's data there that says internalized racism may be bad for your health. And I think we need more research that tries to get at this. I think he's worked now and maybe published on effects on telomere length, but I didn't pursue that for this presentation. Lots of limitations, it's age, it's CV ascertained by history. There tend to be a younger sample, but it does imply a bigger role for internalization. One of the challenges with the explosion of scientific information is incorporating what biological measures can be included in these research that helps explain the pathway. So 30 years ago, you would publish a paper as a social scientist about discrimination. The basic biologists would sort of like not paying attention to it. It didn't speak to them at all. Now we know better. Now we can try to find the common linkages here. So these are the things that have been used. So systolic blood pressure is a physiological measure, the C-reactive protein as a nonspecific measure of inflammation, interleukin-6, another one. These are contained in lots of the, and Haynes data or some of the other data that people have collected in collected blood. Cortisol access has been used a lot. It's hard to measure it in saliva 3 times a day, although if you have very good research assistants, that maybe can happen. But hair cortisol is not bad, and it gives you a month-long reflection of chronic stress. Allostatic load, I think Arlene Geronimo's work was brought up on the screen earlier. This grouping includes metabolic as well as inflammatory and physiologic markers. Telomere length is more recent, and the importance of the early childhood programming of telomeres, I think, is another approach to this. And then sleep, quantity and quality, it now has moved into the, you can monitor sleep, you can figure out how long you actually were asleep, how many times you woke up, not only the self-reported one, which also matters equally. And one that is uncharted territory is brain imaging. There are pretty amazing things going on in the very basics research on the brain. And I'm not referring to just functional MRIs, which are already rolled out, but the whole brain initiative launched by President Obama is led to some amazing discoveries about how the neurons are networked. And I think the basic researchers there don't have any idea, not just whether race matters or social class matters, whether gender matters. And there's a lot of basic important work that needs to be done in that area, which may help us understand a lot of the observations we make in epidemiology and public health that are different and we can't fully explain on the basis of our models. This is an example of sleep from the MIDAS study, which is an NIA-funded study, everyday discrimination scale, and was correlated with poor sleep efficiency, sleep quality, and longer wake after sleep onset and more difficulties. And the differences between whites and non-whites was attenuated by the discrimination scale. So blacks were worse than, or non-whites were worse than whites, mostly African Americans. But all this was explained when you factored in their score on the everyday discrimination scale. James Jackson has published this paper in American Journal of Public Health a number of years ago about how chronic stress is adapted to differently by blacks compared to whites, that whites get more depressed and have higher rates of suicide, both known facts from public health data, and blacks adjust by doing unhealthy behaviors, and these include eating as well as substance use. There's a lot of controversy about this. We weren't able to reproduce the findings in using the health and retirement study. We're continuing to work on other surveys and collaborate with James on this. So I think this is another way of modeling this, of thinking about it, including the biological mechanisms, but also what, your starting point often is, what are we observing in the public health epidemiology? You're just not like guessing, or you have this great idea, but you're usually motivated by what you observe rather than. This is an allostatic load example. There's several dozen papers that have been published. This tried to look through Ann Haynes at differences in women, and they did find higher scores by age among African Americans. Those were less in high school, less income, and formerly married, and U.S. born. And foreign born actually had lower allostatic load across the board. So it's at least evidence of why there might be an immigrant advantage. And then these interactions that were found between whites and Mexicans, but I won't dwell on the end of the results. So I want to also emphasize the model of adverse early childhood events. This has been around for a while. I think it is a critically important concept to use. It's the developmental origin of health disparities, and it's not just about healthy childhood, autism, dysfunction or mental health. I mean, it's about diabetes and cancer and heart disease. So this is what potentially sets us up for disparities in midlife. If you look at the data for where do minorities do worse in public health, it's in midlife. So if an African-American man, the lowest life expectancy in the U.S., not counting American Indians, which we don't have full national data, makes it to 65, they actually do just as well as whites, and in some data better. There's a crossover effect. And Latinos do better as well. So what's going on? What leads to that, that midlife issue? That, somewhere between 30 and 50 or 40 to 65, that age group is where you see the biggest discordance. So this whole issue of stress getting under the skin in kids, intergenerational transmission of social disadvantage, and effects on telomere biology. This is an R01 that's funded, and then identifying and how these predict changes. For example, this is the Family and Community Health Study. University of Georgia investigator Dr. Simmons has a project. These are grants that are funded, not yet coming out with results. So, but I want to emphasize this, and I think there's great opportunity that we can explain more. How am I doing? I'm probably over time, but I'll keep going. So just to make a point, I actually immigrated to the U.S. in 1960, and this was still going on in Miami when I got here. I don't remember sort of affecting me, but boy, it was a difference, and blacks were in the back of the bus. And so in South Florida, which of course Miami doesn't really consider itself part of the South, it's more like North Cuba or something. But this is just to make the point about what does structural racism mean. So this is one image that will communicate that, and some highlights on some issues. So these are data from Irene Yen and George Kaplan from the Alameda County population study. Just as the whole research world of place, built environment, was beginning to take off, it is just as new as the human genome, the whole research on the physical environment and health. And interestingly here, that if you have the lowest community SES, measured with census kind of variables, the high income and low income people had a similar mortality at 11 years later. But if the poor people who lived in the highest community SES did worse, much worse. So what is going on there? And what do we need to do research on this question, which I don't think has been extensively examined. Another research that I like to use in this kinds of context, this is from Mount Sinai in New York, Carol Horowitz, a general internist, and looking at food targets. And say we tell our patients, go eat fresh fruits and vegetables, low-fat milk, diet drinks instead of full sugar drink, although that may not make the list anymore, high-fiber bread, patients with diabetes. And then you go to East Harlem and Upper East Side, New York, and you compare the number of stores that had all 5 categories. So in East Harlem, 9%. In Upper East Side, 48%. And these are the sort of convenience stores, not the full-service supermarkets, which are much less frequent. So if you have chronic disease, diabetes, probably osteoarthritis, limited resources, and you'd say, well, buy these foods, and yet you go to the store, they're not there. So whose fault is it? Is it the patient who's not adherent? Oh, you're not compliant with the diet or to make changes? Or is it some other issues about structure that is going on? I think it's a good example of that, even if it has evolved to some extent, I think. This is another one. I borrowed this from Tom Levise's work, and Tom is very interested now in looking at what the function is of integrated neighborhoods. And he's looking at parallel segregated integrated neighborhoods, and using New York, I think, city as well as Baltimore as his communities. And you can see that in this low-income segregated neighborhood, you see much greater proportion of liquor stores and the targeting of that group, less so in the integrated neighborhoods or any of the high-income neighborhoods. This is data from nursing homes, large data set from Medicare. So you see secondary data to evaluate what happened between 2003 2008. So nursing homes with blacks and whites, this is just a black-white comparison. And you see that the rate of pressure ulcers, a clear measure of quality of care and a bad outcome for chronic nursing home resident went down. So we're making, slow but certain progress. It's the gap isn't decreased. In fact, it's, if anything, it might be about the same. But nursing homes with less than 5% black residents had the lowest rate of ulcers. So what's that telling us about the structural form? These are all patients on Medicare, all patients in nursing homes. There isn't like a magical difference in some of these. Lots been done on cardiac disease. Evidence that from about the year 2000 that if you were African American, you were more likely to die from a heart attack. Variety of other data on cardiovascular disease I'll come back to. But this paper was, I think, telling, and look, again, using it Medicare, looked at race, area socioeconomic status, and distance to the hospital, which has not panned out to be relevant for most cases of management of acute heart attack. And so African Americans with acute heart attack were more likely to go to top-ranked hospitals. They're concentrated in urban areas. Most of these top-ranked hospitals are in urban areas, so that was probably the explanation for that. But if you're poor, in the most disadvantaged zip codes, you probably aren't going to have the top-ranked hospital in that zip code in most cities. And blacks from the disadvantaged zip codes were less likely to go to the highly ranked hospitals. Boston might be an anomaly because so many high-powered medical schools here with great hospitals. But think of this as national data from Medicare. So the legacy of inequality in healthcare is one that we need to own as healthcare scientists. Socioeconomic conditions, poor health among blacks, the Jim Crow laws I alluded to, internment camps in World War II, deportations of Mexican Americans, including many citizens in the 1930s from the Los Angeles County. The Tuskegee syphilis study, which is quite well known to all of us, and although you can't see it on the slide, it's blotted out by my poor formatting, the Pima Indians in Arizona are an equally burden of shame, I think, for science, given that they were observed to develop diabetes and nothing was done about it. For years and years, papers in the New England Journal, NIH was in part responsible for that. But what triggered it was the Indians lived in the area where there was water in what later was to become Phoenix. So the developers came and said, we'll give you all the food you can eat. You don't need to work for your food anymore, and you'll give you housing, but we need that water. And then you say, oh, good deal. We'll take our water. And of course, they all have this genetic predisposition to become obese. And if they become obese, the rate of diabetes is incredibly high. And so the Pima Indians were the classic model of diabetes that I learned about in medical school. But it was built on a really inequality and an injustice in the care, in the way this research was done. Lots of stuff some stuff on discrimination in healthcare research. There was a famous study done in the UCLA emergency department where Latinos with long bone fractures were significantly less likely to get any kind of analgesic, not opioid, but ibuprofen. That has not been replicated in other places, so I think practice kind of changed. People became more sensitized to that. The referral of patients with chest pain to a cardiologist. This is a scenario study that was published in the New England Journal. Kevin Schulman was the lead author. It was prompted by that Dr. Satcher had his press conference announcing the whole issue of health disparities is when the term became popularized. It turned out that the analysis was flawed, and it was really only black women who were less likely to be referred. The analysis for black men was not robust, and it was significant. Maybe it was good because we now learn that coronary bypass surgery is actually not needed for most of those patients, but intensive medical management is actually just as good in most cases. But that's 10 years later. The acute MI mortality being higher. And then in general, a number of studies showing that referral for technical procedures, there was consistent disparity in the referral. So if you had early lung cancer surgery, you get a shot for cure, blacks are less likely to get it. Referral for transplantation, kidney transplantation, life-saving or take you off dialysis, you got to go through a number of hoops to get to a transplant nephrologist. And to do that, the barriers are huge. So it's not just race, it's also socioeconomic status, it's health literacy, there's a variety of factors. And then we talked about the coronary surgery. Among non-English speakers, this is actually done in a Boston hospital, interpreter use and readmission rate showed that if you did not use an interpreter at all, during your hospitalization is over a year study, your likelihood of being readmitted to the hospital within a month was 24%. Now, most plans would say, well, 15% seems to be the floor. You might get it lower than that with new discoveries. But, and you know, it's embarrassing that patients are hospitalized, don't speak English, and they get seen by an interpreter at discharge only or admission only. And we did our own surveys in San Francisco on this and found you know, a similar kind of data where the use of professional interpreters was exceedingly low. This is a structural disadvantage that's discriminating against people who don't speak English. So we think language concordance matters. I won't dwell over this. The generating empirical data to support this common sense statement. You talk to the patient in the same language, it's going to be better than not talking to them, talking to them you know, through an interpreter or doing veterinary medicine like many doctors do. That means you kind of do hand signals, or you examine and you say, see you later. But you know, it's important to have generated empirical evidence that there's less errors, there's better quality, and now recently a paper published in JAMA Internal Medicine showing better diabetes care, better diabetes control, for which we wrote a commentary. Let me finish with touching on unconscious bias. I think it's as a concept to sort of capture some of what was mentioned earlier. Talking about disabled patients. And so the social stereotypes of groups and individuals from outside their own conscious are aware. And you know, you can go to the website, it's Harvard Implicit Association Tests. I've taken it a number of times and do it. It's an exercise in awareness. It's actually quite good if people actually do it right and then have a group discussion about it. Because there's nothing wrong with having unconscious bias. I mean, you grew up in a world and a culture that's different than it is today, and there are going to be bias. If you ignore them, or if you try to deny them or they don't exist, you know, it doesn't help. It's sort of basic, you know, Freud 101 or psychodynamics. But it gets some awareness, and then it allows you then to manage the situations better. And you know, there's a fair amount of you know, data about, you know, men are favored over women, whites over other groups, youth or better appearance. I mean, the marketers know this very well. And then physically able, as was alluded to, as was discussed earlier. Not a whole lot of data on this, but some medical student bias in recommending obese patients versus non-obese virtual patients. Obese patients had more negative stereotyping, less anticipated patient adherence. So, we funded a study, one of the studies we fund in South Dakota is a Center on American Indian Health, found in a study, and this is published in Medical Care last year, 84% of clinicians had implicit preference for whites. These are taken care of in areas where they see a lot of American Indians. And the greater number of American Indian children seen, is focused on kids and their caregivers, the more clinicians saw these American Indian children, the more they saw them as challenging. So the volume of being exposed to them didn't help deal with their unconscious bias. And they saw the caregivers as being less compliant. So again, it documents what appears to clinicians maybe working in this setting to be an obvious problem, but then you get data to support it, and then hopefully then leverage changes in the health system, and the quality improvement to do this. So few sort of tidbits about how we may do better. Supportive parenting, early childhood education. Recent data showing how early childhood education changes in the last 10, 15 years, 20, whatever it has been, but really an emphasis in the last 10 years, has narrowed the achievement gap in kids, poor kids and minority kids getting into kindergarten. And it's not equal, but the achievement gap is narrow. So this is doable if you get better preschool opportunities for poor children. The whole, you know, what factors might, you know, racial socialization, supportive relations, so network, sort of the power of talking and interacting with people. So what people fear the most is things they don't know. And if you are able to then socialize people in that fear, will that be a basis of decreasing this effects of racism and discrimination? I think that's sort of the rationale behind integration. Although what happened was you force integration, you lose identity, or you lose cohesiveness in the communities, and then that didn't work. So that's another of the other factors that have been shown to improve this: social cohesion, having more interactions, religiosity as a sort of organized community activity. There's some encouraging data on meditation and mindfulness as ways to blunt the stress response that occurs from being discriminated against. No data on physical activity, but I would just propose that that's potentially a good sort of coping mechanism. You feel stressed from whatever's gone on in your life, you do physical activity as opposed to drink. And I think that would make sense. Some data that if you have patient-centered medical homes, you ablate, you diminish or eliminate some of the differences that we have seen historically in between poor and not poor, or white and non-white, in terms of diabetes control or appropriate screening or other such things that we often say it's access, but it's not just insurance, as was mentioned earlier. And then addressing cultural competence, which links to the implicit bias issue of how we educate our clinicians to really feel comfortable taking care of. I mean, we went into those of us who went into clinical medicine did it because we wanted to do medicine. We like people, and we're in favor of that, social justice and humanism. And so in order to do that, you accept everything. Yes, there are undesirable patients, as you pointed out. Yes, there are patients who are more challenging medically, but the mantra has to be, you see every patient. As a generalist, that has to be. We have no choice. We pick we don't pick our patients, as perhaps some specialty groups can do that. And I think that addressing that is going to be at the core of this. So thank you for your attention, and I think we'll do comments at the discussion. Right? Yeah.
Thank you. I really appreciated your comments, Dr. Pérez-Stable. They were perfect, exactly what we needed. Next, I'd like to introduce our moderator for this panel, Dr. Thea James, who is Vice President of Mission and Associate Chief Medical Officer here at Boston Medical Center. Dr. James has a strong, long professional career in emergency medicine, both inside the United States and outside. She's won awards for public service, importantly, awards for being a compassionate caregiver. And I want to say that she's a new colleague of mine, and I have had so much fun and energy from working with you over the past year. So thank you, Dr. James, for moderating this panel.
Good afternoon, everyone. Dr. Bachman and Dean Kelleher, I don't see you at this moment, but there you are. I just want to say thank you so much for the honor to be here today as a moderator with all of these fantastic speakers. As Dr. Bachman said, I'm an emergency medicine physician, and I happen to be an emergency medicine physician at a hospital where nearly 80% of the population is government insured, which means that you have an opportunity to see many things every day, lots of things. And I feel as if my patients have taught me everything that I know. But I also feel like we have not necessarily taken every opportunity to teach our residents and students about what we're seeing, because you see a lot of the same things over and over and over again. And in medicine, you're sort of focused and taught to focus on disease and what's sitting in front of you. If somebody comes in with their hypertension every 3 months, they get admitted because their blood pressure is out of control. And every time you see them, you just try to fix the blood pressure. You just miss opportunities to figure out things like what's actually driving it. So a lot of what I tell my students and residents is, if you can only remember 3 things, particularly when we're talking to them about social determinants of health, is to say, don't make any assumptions about what you see, because you're just rolling the dice. Wonder why you're seeing it, and engage the patient to find out the reason to break the cycle. Because you actually, if we say that we are here for the mission, and many people, almost everybody will say that they're here for the mission, then from my perspective, it should be like what Dr. Kelleher said, is to move the dial, to move forward, not to just perpetuate the cycles. So that's what I use when I'm showing my residents a slide like this, that they find hard to believe, that we spend more money than any country in the world, but the outcomes are not like that. So I've gone to teaching my residents this, helping them to understand that the structural things happen outside the hospital, but they absolutely are driving what's going on inside the hospital. And at this time, where we're moving away from fee-for-service to value-based care, where we're being held accountable for outcomes, I think it's the greatest opportunity for us to actually move the dial and to do things on behalf of our patients. So I'd like to introduce our first speaker. And Dr. Pérez-Stable, thank you so much for your presentation. Sorry there. Our first presenter is Dr. David Takeuchi, who is the professor and Dorothy Book Scholar and Associate Dean for Research at Boston College School of Social Work. Dr. Takeuchi is a sociologist, and his research focuses on the social, structural, and cultural contexts that are associated with different health outcomes, especially among racial and ethnic minorities. He also examines the use of health services in different communities. Dr. Takeuchi.
Well, thank you so much. I must admit, though, as I sat in my chair there, I was starting to feel ill, because when I first heard about Dr. Marapia's sense that he can speak 7 or 8 languages, I can barely speak 1. He's a master swimmer, I'm a master drowner, and that he took 1 year to study inequality, inequities, and he produced this eloquent talk. I've studied it for a lifetime, and you know the rest. So one of the things, I think this is a very timely conference, because it really moves us away and takes our minds and our hearts and souls to discuss an important issue. And it moves us away from what has consumed Boston and New England for the past 2 years, that pressing question about what did Tom Brady know and when did he know it? And now you know why I went into sociology. So I want to, I'm not using slides, but I have some narrative bullet points that I'll use to frame some of the comments I'll make here. And I'm going to briefly touch on some structural features of inequality, talk about some of the social processes that lead to inequality, and then I'll give you some examples of what I think reduces structural and the social processes around inequality, 2 in Boston and 1 nationally. And I'll try to do this in my allotted time. I'll focus on the middle out kind of strategies that have an effect on social policy as well as on individual lives. Much of what we've talked about has shown time and again that inequalities exist. And this has been true, and much of our research has documented. We've done a great job in documenting these inequalities. We haven't been as successful in showing why these inequalities continue and persist over time. And in my line of work, I study both the social factors that lead to health problems as well as some of the health access that concern different communities. And in my line of work, one of the key findings was in 1971, Stanley Su and Herm McKinney in their classic study showed that racial and ethnic minorities are less likely to access care when they have a health problem. And when they do access care, they have less quality care. If you fast forward to I'm lost in where I am. Fast forward 46 years later, and what do you find? Racial ethnic minorities are less likely to access care, and when they do access care, they get poorer quality care than whites. So what do we count for this persistence of this kind of inequality? So I'm going to talk about this notion of durable inequality. Charles Tilly and Doug Massey, two sociologists, argue that there are two facets of institutions that lead to this durable inequality. That is the exploitation and opportunity hoarding. And a focus on these exploitation opportunity hoarding is key because it not only focuses on the individual that may experience these kinds of inequalities, but it also focuses on the privileged, the advantaged few who perpetuate these kinds of inequalities. And this is important because recent research shows that the wealthy, especially whites, have become increasingly more isolated from people of color. And this isolation produces the reliance of stereotypes and support for regressive policies. Exploitation refers to discrimination against one group that constrains another group from reaching the full value of their effort. Often cited example is women receiving less pay than men for the kind of same work and qualifications. African Americans, Latinos, and Asian Americans often have fewer rewards from their education compared to whites. Opportunity hoarding happens when dominant social groups restrict access to important resources. So one example is that when racial and ethnic minorities achieve a certain point, they reach a glass ceiling and don't achieve the kind of social mobility rewards that whites receive. So these are kind of the social factors that produce inequality and the persistence of these inequalities over time. There's a number of social processes that lead to inequalities, and I'm going to mention three of them. One is othering. Othering is a collective identity where members of powerful groups create or reproduce inequalities by defining members of other groups, such as racial, ethnic minorities, religious groups, immigrants, and sexual minorities as morally, culturally, or intellectually inferior. Since these are others and not us, we often treat these others through discriminatory practices. For example, immigrants such as Muslims are denigrated and seen as others and seen as divorced from the kind of US norms. Recent Pew reports showed that 45% of Muslims have experienced some form of hate crime against them. Another form of social processes is the subordinate adaptation. And this is a notion that people who experience some form of discrimination find different ways to adapt to it. One of these kinds of adaptation may be that people may drop out. For example, youngsters may drop out of school if they experience some form of discrimination. Others, if they find that the mainstream society may not produce the kinds of advances that they experience, they may join other kinds of groups, for example, gangs, as a way to adapt to these kinds of treatment. Another form of social process is boundary maintenance, where dominant group members preserve their symbolic, interactional, and spatial divisions for themselves, and members of the subordinate groups are excluded from these kinds of rewards. For example, you can see this in access to different kinds of prestigious colleges or certain kinds of clubs. So one of the major parts of these kinds of forces and processes is that there are mechanisms by which we can address them through different kinds of programs. And I want to turn your attention to 3 kinds of programs, 2 in the Boston area and 1 nationally. One is called the Inner City Weightlifting, which I've had the pleasure of working with. Inner City Weightlifting, or ICW, was started in 2010, and it's housed in an undisclosed gym in Dorchester. And the reason it's in an undisclosed gym is that because many of the members belong to gangs, there may be forms of retaliation, so that they try to keep that gym a secret. One part of ICW is that students who want to become trainers are given certificates to work with high-end or high-income clients in Boston City. And the reason this is important is because when the students work with these high-income clients, they have the power for a temporary period over these high-income clients. So the notion is, can you actually have some real change in these kind of 1-hour interaction that has more long-term consequences, both for the student and for the client? So that's Inner City Weightlifting. It has expanded to another site in Kendall Square, and it is looking into developing another program in Philadelphia. The other program is United Teens Equity Center, which is a social enterprise in the Boston area. The UTEC takes a patient mad love approach, or an unconditional approach, which creates a family environment to work with young people. And the core value is to work with these youngsters to develop certain kinds of skills that provide them with a job and support for their families. And the notion is to not only work with these youngsters, but have an influence within the larger community of bringing community residents into the program to change community lives as well as the lives of these teenagers. My third example is one that's recently started in Watts and Oakland, and it's actually quite an interesting one. It's developed by Roy Choi and Daniel Patterson, 2 celebrity chefs who formed the idea of revolutionizing fast foods, where they're bringing fast food items, minus French fries, with less fat, salt, and calories at low price points to residents of impoverished neighborhoods. They started the mission with the notion that giant corporations feed most of America, have degraded communities by maximizing profits over decades. Chefs should feed Americans, not suits. Fast food restaurants can truly empower the communities they currently underserve. The intent is to build this concept over the nation. And one of the fascinating features of this effort, and it just started, I think, with the past year, is to not only employ youngsters from the neighborhoods, but also to help change the communities and revolutionize the way people are thinking about diets and nutrition. These are 3 examples, I think, and there are many more in different communities, which take a middle-out position. That is, they're not policy or organizational on a large scale, and they're not necessarily focusing just on an individual, but they have the capacity to explode and expand and have an influence on a larger social structure as well as on individual lives. And I think a lot of these efforts bear watching and research and support to see if they can, over the long term, change these kind of durable inequalities that have persisted over time. So anyway, thank you very much.
Thank you, Dr. Takeuchi. Our next speaker is Dr. Kelleher. Dr. Kelleher is a professor of pediatrics, psychiatry, and public health in the Colleges of Medicine and Public Health at The Ohio State University. He is also Vice President of Community Health Services Research at Nationwide Children's Hospital that focuses on in his work, on collaborating with neighborhood leaders, community agencies, and related partnerships to improve some of the social determinants of health, such as housing, employment, schools, and safety on the near south side of Columbus, Ohio. Dr. Kelleher.
Thank you, Thea. I want to say that I'm grateful again to the opportunity from Boston University to be here, and especially for that enviable position of the last thing between you and lunch. So I am going to talk about the social determinants of health, but I want to do so in telling you a tale of two cities. 10 years ago, I moved back to Columbus, Ohio, the first city, and found a city radically different than the one I had left 30 years previously. The city is one of the fastest growing cities in the United States, is now 14th in size in the entire country. It has a rapidly expanding population, one of the lowest unemployment rates in the country. It's now home to Fortune 15 companies, a number of them, and overall, of course, the Fortune 500 has 14 companies that are now headquartered. There's a want of laborers, there's rapidly growing economy and explosion in the population. In the last 10 years, 250,000 Latinos and 90,000 Somalis and Somali Americans have moved there for various reasons. So the city is exploding on all fronts. And the crown jewel in that city was the place where I worked. Nationwide Children's Hospital recruited me to work there. And it's a $2 billion a year enterprise with 11,000 employees. It's the largest pediatric hospital in the United States. Has over 500 pediatric faculty from Ohio State University, is now ranked in the top 10 in research funding. It's the largest volume of patients, and has referrals from dozens of countries around the world coming in for the best medical care. The city and the community have invested heavily in that, and we just finished they had finished a 10-story, $1 billion bed tower when I arrived. And the board turned around to the community and said, how can we have the world's best outcomes? And we had already achieved the safest pediatric hospital in the United States, some of the best outcomes for specialty care, all specialties ranked in the top 10 in the United States. But there was a problem. And that problem was the second city, the Columbus Shadow City. There are 9 out of Columbus's 275 neighborhoods that account for half of all the gun violence in the city. They account for 30% of all the infant mortality in the city. 5 of the city's 8 failing high schools. They account for a complete lack of job opportunities. Needless to say, those were the neighborhoods that were redlined 80 years ago and became the segregated neighborhoods, largely African American, a large chunk of Appalachian, and the rest of the minority community. And that population showed up in our statistics for the city. Infant mortality that was among the bottom third of the United States for the city, with black infant mortality being 3 times that of white infant mortality. We have asthma rates that are among the worst in the state. And again, black outcomes far worse than white. We have continued progress in suicide rates. So suicide rates in Ohio, and frankly across the country, have not gone down. Psychiatric disability, children on antipsychotic drugs, among the highest in the country. And rates of opioid use and opioid deaths in Ohio among the top 5 in the country. So we actually have 2 different cities in Columbus, Ohio. We have almost a 0 unemployment rate and rapidly rising economy, and among the lowest infant mortality and other scales among certain populations, and then among a very small set of neighborhoods, we have very, very high risk. In fact, when I confronted the Chamber of Commerce director with this at a public meeting, he said I must be either lying or confused, because Columbus would never tolerate such a thing. But it actually took an awareness of that before the city was able to grasp with it. But they have come around, and the hospital said, what do we need to do? And the answer, after looking at the literature that was presented this morning, and is that the neighborhoods were ill. The neighborhoods were unhealthy. The people, in part, some of the evidence that we saw, have very high rates of unhealthy behaviors and other things, a lot of which is driven by their choices, limited choices they have in their neighborhoods. There's a constant science that was reviewed by our board of directors, and they agreed that the South Side neighborhood in Columbus would be our first target neighborhood, and we would seek to try to change the outcomes focused on the social determinants of health in that neighborhood. They accepted the biology that is growing by the day, that where you live matters more than your gene. They accepted that there are effective interventions for changing social infrastructure, that there are housing interventions that have been shown to work in randomized trials. There are educational interventions that do change school performance. There are employment interventions that change employment opportunities. And there are cultural interventions that may change culture, the last being the uncertain one. And the accountants accepted the fact that the return on investment for the hospital might actually make sense. And I'll explain that in a moment. So why would a large pediatric healthcare institution take on the challenge of affecting neighborhood problems? There is the moral question, and for all the public, we said it was the right thing to do. We told the newspaper it was the right thing to do. The physicians and the nurses wanted to do it because it was the right thing to do. But at the bottom line, this is a large corporation with a business model. And there are two main reasons that large healthcare institutions can and will need to do more of this in the future. As we go to value-based payments, we were capitated, fully at risk, for all of the Medicaid children in the community. And this was one of the highest cost communities in the entire 34-county region that we were capitated for. We have the largest pediatric accountable care organization in the United States. It is a $1 billion contract every year. And with children who are using the emergency room at very high rates, being admitted for very high rates, and having extreme high rates of prematurity in the neonatal intensive care unit, our neonatal intensive care bill alone was over $55 million last year for Partners for Kids, our accountable care organization. So there's a financial incentive to try to have a long-term effect on the health of the community. Secondly, it is a political imperative. The hospital is expanding rapidly, had several bad press incidents from being a bad neighbor, paving over homes to put up parking lots, right? To not considering the neighborhood in its growth plans. And that all happened in the late 1990s, and as a result, the hospital began attending more and more area commission and neighborhood commission events, more and more opportunities, and learning that housing was a major problem on the South Side. And in fact, just across the street from the hospital, the vacancy rate was 31%, by far the highest in the city. So almost 1 out of every 3 properties was abandoned within the city neighborhood. Employees didn't feel safe, patients didn't feel safe, and most importantly, the residents of the neighborhood did not feel safe. Politically, the mayor said, I have transportation dollars to fix up the streets and street lights near you from the Department of Transportation. I have neighborhood stimulus dollars. The governor said, we have early childhood education dollars. Who's going to help us spend these dollars? The hospital said, we can do that. We can run programs to help you fix this up. We can help you coordinate this. We can leverage your money. We can double sometimes your money. And so the board agreed to a 20-year plan in partnership with the neighborhood residents to try to make the South Side of Columbus the healthy neighborhood, healthy family zone. What does that mean? Well, first there were principles. It was going to be place-based, 2-generation intervention for 20 years, minimum. because it took 80 years to build this problem. It's going to take a minimum of 20 years to turn it around. It had to be neighborhood-centric and co-production. So co-production means we are all producing the health of the community together. We are all neighbors together. It's not we're the healthcare and you're the neighbors. We are all the neighbors. And as a result, co-production also means United Way, Church for All People, Neighborhood Pastors Group are all part of the initiative as well. We also had to be evidence-informed and relationship-based. Evidence-informed, best practice, we steal shamelessly from everywhere something has worked. And relationship-based means we are doing it to change each other's culture. Because in any relationship, you have to learn from your partners. And in those relationships, in the hospital, we are working on poverty simulation classes. We are training our leadership on mentoring students in the high school, including our CEO and other leaders in the C-suite. And we are asking neighbors to take classes on neighborhood leadership. What's a 501c3? How to run a meeting? What's an agenda look like? How to do a grant application? And developing leadership on both sides to talk to each other. So a common language is developed. We also have a focus on sustainability. No grants unless there's a long-term sustainability option behind it, because the neighborhood had been dumped on many times on people coming in for a year or 2 years or 3 years. So grants are great for startup, they're great for training, or they're great for adding evaluation, but otherwise that's not acceptable. And it had to be outcomes driven. The outcomes are unusual for a hospital. Things like unemployment rate in the neighborhood, number of crimes per 1,000 residents, personal property crimes and personal crimes, graduation rate at South High School, kindergarten readiness, including emotional and developmental. So we ended up with 5 main domains, and the 5 domains are employment, safety, housing, wellness, and education, trying to focus on both generations. I have a lot to say about all of them. In the housing area, which is the one that most people like to talk about, the hospital has invested $9 million over the past 6 years, but that's been matched by $28 million from other funders, including United Way, the city, many other players, private developers, and that's resulted in improvements to 450 homes, and the vacancy rate in the census tracts I told you about has gone from 30% to 6% in that area, and the quality of the housing stock has risen considerably. We're also adding that at least 40% of all added housing is low-income housing so that we don't gentrify or exclude residents. And the engagement have become the most popular things. And so there are metric-driven and evidence-based programs, but then there are the things to actually engage community and build third places where people can gather of different types. Because you have your first place where you live, your second place where you work, and third places where people gather, and they have to be mixed kind of places so people from different cultures do meet and engage with each other. And those third places are things like the bike co-op that's been jointly sponsored by a variety of employers in the neighborhood, the Neighborhood Leadership Academy training, and the youth development programs that include a documentation program, blogs, and picture taking for the teenagers. So I would love to talk much more about each of the arms. We have many programs in each. The hospital's committed most of the resources, but the neighborhood's done most of the work. And in exchange, we're building something that I think has a chance to overcome some of the structural hurdles, because I think we can do a lot of the intervention programs to ameliorate structural racism and poverty, but unless we change the true poverty, we're missing the boat because we're dealing with it after the fact. I would just challenge this group, though, because I feel like I'm back at the College of Public Health where I teach once a year, and we're talking to ourselves. I don't see the large Medicaid managed care companies that are present here. I don't see the politicians that are here. I don't see the Federal Reserve, who has a very large housing structure program here. And to be honest with you, in most of my meetings, the people from the College of Public Health are the least helpful because they point at the problem and, sorry. So I'm challenging us to go beyond continuing to identify the problem, and I know that's the intent is to move forward, but we need the right people to move forward. So we have to speak to the people with resources and dollars and the neighborhoods in order to truly do that next step. So I would just leave you with our dollars are disproportionately spent in the healthcare environment. You have one of the country's very largest children's hospitals right down the street, and those hospitals have both an obligation and a business case to make for investing. I hope we can figure out how to do that together. Thank you.
Thank you, Dr. Kelleher. Our next speaker is our very own Dr. Tracy Battaglia. Tracy, I should be able to do this without even looking at this. Dr. Battaglia is the Associate Professor of Medicine at Boston University School of Medicine, an Associate Professor of Epidemiology in the School of Public Health, and she serves as the Director of the Women's Health Unit in the Section of General Internal Medicine at Boston Medical Center. She's also the Director of Women's Health Interdisciplinary Research Center at BU School of Medicine and Director of the Community Engagement Program for Boston University Clinical and Translational Science Institute. Dr. Battaglia.
Okay. Good afternoon. I was just told keep it to 10 minutes because you guys are hungry. So I want to just start by saying it's really a delight and an honor to be here. I'm really humbled to be among this group, to have this conversation. Dr. Bachman last evening challenged us to think beyond our silos in our remarks and our conversations today. And the unique perspectives that we've heard up until now, I think, starts to get us to be thinking about that. And so I want to share with you the lens with which I'm going to share my remarks, and that is as a primary care doctor who has the privilege of caring for patients that happen to be inner city patients. I'm going to share with you some of the work that we do in our Center of Excellence in Women's Health and the framework with which we approach these issues of inequity, and share with you one large success story, but then share with you the challenges that lie ahead of us. And while we've made some progress, we still have a lot of work to do. So because of the prevailing health disparities in our country, we're all accustomed to this common term of priority populations, right? So those are the populations who have the most persistent and egregious health outcomes. And for those of us who do this work as researchers or in public health, we know who they are, right? There are the racial ethnic minorities, the low-income groups, women, children, older adults, residents of rural and inner cities, and individuals with disabilities and special needs. And so in the city of Boston, like cities across the entire country, women happen to be among several of those priority population. And getting back to the remarks of this morning around the intersectionality of these different populations and groups, women sort of fall into that group. And so they often suffer the worst health outcomes. These disparities are particularly pronounced in reproductive health and sexual health, where women of color fare worse than white women in almost every aspect of reproductive health. I know this audience knows this, but I still think it's worth remembering. African American women die in pregnancy or childbirth at a rate of 3 to 4 times the rate of white women, and this has been true for over 50 years. Nearly all minority groups contract sexually transmitted infections at much higher rates. Together, African American women and Latinas account for 80% of reported HIV/AIDS diagnoses, even though they represent only 25% of the US female population. I can go on and on with these statistics. We know that women's health is much more than reproductive health, and as a primary care internist, we focus a lot of our activities around chronic disease prevention. And so near and dear to my heart is cancer care disparities. Despite advances in screening and treatment for breast cancer, Black women and women of lower socioeconomic status remain more likely to be diagnosed at later stage and to die more often from breast cancer. And while there are many reasons, and we've heard about them this morning, to explain these differences, and they range from biology to geography, the science is also pretty clear that if we can get all patients to get the same care, a lot of these health differences disappear. And so the work of our group is really focused on this critical disconnect from scientific discoveries to delivery to all populations. And so I have the honor of directing our Center of Excellence in Women's Health, and the work that we do is focused all around that issue. So the vision of our Center of Excellence is to improve the lifelong wellness and health for all women by transforming healthcare delivery, trying to ensure that all of those scientific discoveries get to all the women who need them. And so we do this through integral partnerships with all stakeholders. And so we've heard a lot today about who those stakeholders are, and some of them are in the room, but perhaps they're not all represented here today. So I'd like to share with you a short story about one of our success areas, or at least an area I thought for some time we had successes. And that is in the design, evaluation, and dissemination of patient navigation. So raise your hand if you've heard of patient navigation. So a lot of hands going up, great. So patient navigation is a growing healthcare delivery model that was specifically designed to address this disconnect between scientific discovery and delivery of cancer care treatment for vulnerable populations. And so when I joined Boston University many years ago, I started caring for patients with, around breast cancer care, and we found that we achieved parity in this state pretty early on in achieving breast cancer screening. But when we look to see, we know that screening is not going to improve health outcomes unless we follow through on abnormal screening, right? And so my early work here demonstrated for me that when women had an abnormality, either on their breast or their cervical cancer screening tests, more than 50% of them in the city of Boston did not follow up on those abnormalities. And so that early work led us to asking and understanding why that was the case. And not surprisingly, we looked and talked with all of the stakeholders, patients, care providers, health systems, and we found, not surprisingly, that the health system's complicated and complex. We know that that's the case. But we also learned from women that a potential breast cancer diagnosis is actually not the most pressing issue in their life. And it was then when we started to uncover these social determinants of health that were really getting in their way of accessing care. In the city of Boston, where I would argue we've had access through insurance reform for many years, at least during the majority of my professional career, and have how many institutions that are the best institutions in the country providing services, there should be no access issues to delivering this care. But yet our patients are telling us that their social issues at home were interfering with their ability to access services. So we said, okay, let's partner with all of our stakeholders. Let's get the patients in the room, the providers, the health systems, everybody at the table, let's talk about solutions. And we designed what we called at that time a care coordination program, where we took a lay health worker who was culturally congruent with the population, and we said, the providers don't know how to do this. The providers don't have time to do this. Let's integrate them into the healthcare team, help identify what these issues are for these vulnerable women, link them to existing and available resources that are being underutilized locally, and let's see if it improves outcomes. And lo and behold, we were able to do that. Because of our early successes, we were selected as one of 9 sites for the National Patient Navigation Research Program, which was funded by the National Cancer Institute. And so I will fast forward sort of 5 years of this multi-site intervention study where we were able to demonstrate the efficacy of these culturally congruent patient navigators in the most vulnerable populations across the country to reduce delays in both the diagnosis and the treatment of cancer, breast cancer, cervical cancer, colorectal cancer, and prostate cancer. Great, right? Great success story. And then what followed on that, at the time our publications were coming out, the American College of Surgeons Commission on Cancer added patient navigation as one of their accreditation standards. Patient navigation is mentioned in the Affordable Care Act as one component of the patient-centered medical home. Patient navigation is proliferating. Everybody has a patient navigator. They're being advertised on television. This is success, right? Well, that's what we thought. And then in 2014, our colleagues at the University of Chicago Urban Institute published a study. They looked at the top 50 states and looked at black and white mortality ratio for breast cancer. The top 50 largest states, and guess what they found? Boston was among the top 5 worst. So what have we done? What have we done right? What have we done wrong? We've demonstrated in efficacy trials that we can improve care. But what we haven't done is implemented them in real-life settings. Instead of reducing those disparities, we have the potential of perpetuating those disparities by not implementing them appropriately. And so that is an example of how we are well-intended, but an RR1 does not equal a return on investment, right? And so we have to figure out how to translate this evidence into delivery in real-life settings. And so I believe, and the work of our group is strongly focused around these issues in bringing the right stakeholders to the table. And so I'm proud to say that in the city of Boston, we have come together. We have developed what's called the Boston Breast Cancer Equity Coalition, and it includes all stakeholders, the payers, the policymakers, our public health practitioners, community members, patients, to try to come up with solutions that will be sustainable over time. I can't tell you we have those solutions right now, but we have the right people around the table. And I'm very excited to be part of this conversation today because I think in order for us to get to where we all want to go, which is health equity, we have to work together and utilize our community stakeholders to get us there. Thank you.
Thank you. Thank you, panelists. Tracy, don't go too far. So if the panelists could come up, we'll take a few questions before we break for lunch. So, Thea, you're going to be the moderator. So we'll take a few questions from the audience. There's one in the back. Over.
Hi, my name is Reginald Tucker Seeley from the Harvard T.H. Chan School of Public Health. And my question is for Dr. Kelleher. You mentioned that the places where you saw the worst health outcomes were the places that had been historically redlined. So I'm curious about what the process was like, sort of wrestling with that history to get to the place to where the interventions were developed and accepted by those communities that had been historically marginalized.
So I don't want to say that all the communities are ready yet. We have, in fact, in Columbus, one of the things the South Side neighborhood is right next to Nationwide Children's Hospital, and we have many good community quarterbacks. So there are 2 or 3 ministers and a church school there that are all very well connected with the neighborhood and who are our partners and are effective at translating our corporate speak. The Linden neighborhood north of us, which has just as much devastation and slightly more gun violence, is still angry. And when we are trying to do things up there, we are not making nearly the progress. So this is not a uniform, it's an individual neighborhood by neighborhood battle to try to change history overnight. So it is a long grind, and we spend a lot of time on listening. And the first 2 things, there's one of the ministers says it's listen, listen, love, love, and as the first 4 things you do. So, and that's really the answer. So it just takes time. I don't know if that answered your question, but.
Sorry. Is there a question here?
Hi, my name is Lauren Clark, and I'm from the Northeastern School of Nursing. And I know that you said that one of the issues was with public health professionals in general, but what can I do as a future nursing professional to kind of move us in the right direction?
Yeah, I'm being very critical, obviously, to try to provoke some engagement. I mean, public health is the field that defines the problems and points them out to us, and we need that. And that is a critical first step. It also should be the field that tells us if we're succeeding, because we can't evaluate our own interventions. We need public health professionals to say, you are making progress, you're not, here's how you're doing, these are the measurement tools, these are the best new scales and surveys. But as individual clinicians, I think we have to realize that when we're seeing patients in a clinic, that's the smallest part of their lives. and it may not be the most important by any means and usually isn't. So that we have an obligation to know their social circumstances as well as we know their blood pressure, and we have an obligation to make sure that we are true neighbors in the community that we're serving.
Can I build on that? So I think that's a really fabulous and excellent question. And I think getting to the point of, I teach all of my trainees and mentees to, when they think about their approach to their clinical care or to a research question, what perspective is not being represented through your ideas? And so you only have one perspective through your training lens. But what we need to be doing is when we look at the problem, we need to understand who are all the stakeholders who are trying to address this same problem. And we need to bring them together in the room to help us think about our approach, because our approach might be a great idea in our silo. But when you bring in the other community stakeholders' views, your approach may change drastically based on those perspectives. And so what I would say in answer to your question is, know who your stakeholders are and engage with them.
Other questions? There's one there.
I'm just wondering if we're talking about reducing disparities and inequity. It seems like a lot of people who have the advantage medically are often rich or in positions of power. And how does that come into effect when we're trying to change policy, as the people who would be in charge of changing it are often perceive the change as their health care would be of a lower quality, as people who are currently experiencing lower quality gets better?
Do you want to go ahead? So the question, as I understand it, is how do the people who have resources feel when their care might be diminished if we address all the disparities that are there?
Right, or the perception of diminished care. Yeah.
You know, frankly, I actually think most people understand that when we do a better job of care, everybody's care gets better. All the studies that have looked at care for VIPs show they have worse outcomes. All the care when we segregate people in clinics and do special things for high-income people, they don't do as well. And actually, the people who spend the time on our board and listen to the evidence and what we're doing, they are convinced that if we can raise the quality of life for all the neighborhoods, that not only will their health care get better, but their companies will get better. They'll have better employees, they'll have better staff, they'll have less time off work. I mean, they're concerned about their workforce. They're selfish people. They're not doing it for the love of all humanity. This is because it's helping the community, including their workforce and their healthcare system. When we have no-shows in the clinic, when we have appointments filled up with people who don't come, who can't make it, when we have people who are struggling in their homes and we have to send out home visitors because things aren't going well at home, that's a challenge to the whole system and a drain on resources. They know that. So even if we don't care what their motivations are, it helps to move the system forward if we can solve the problems of inequities for the community.
Okay, I can add something. I believe that the issue of the cost of health disparities has been looked at, and it's in the $100 billion plus. So from a sort of the top economic group, if they care about, are we spending too much money on this, it's actually a cost decreasing intervention to decrease disparities if we were able to do this, if we understand what's. And the other thing is that we do a lot of stuff in clinical medicine that isn't evidence-based, that is expensive, that is not supported by any good data. And access to that kind of care, is not necessarily better care. And in fact, the quality of care, as evaluated in regards to socioeconomic status, there might be a gradient there, but it's not nearly as steep as you might guess in terms of getting indicated tests. I think the idea of getting over-testing, access to drugs which are not yet proven, or treatments, or surgery, all of which are high-cost interventions frequently, that's easier to access if you have certain kinds of insurance, but there's no support There's no data to support using them. And so I don't think it's as straightforward as, the pie is limited. If we make you better, that means there'll be less for me. That's really doesn't really work that way exclusively. So.
And I would just add from an economic point of view that giving appropriate care does reduce the reliance on emergency services, which is often used inappropriately by different disadvantaged groups.
So I'm going to call the prerogative of the chair and say it's lunchtime. So what we're going to do is take maybe 15 to 20 minutes. Lunch is available in the back of the room. Stand up, stretch, nutrition, hydration, and we'll come back in 15 or 20 minutes.